Great.
You're back, okay?
I feel
You
better
okay?
turning that way.
Okay, so, okay.
Massage right before I got here. See?
Hello, everyone. Hello again. I am Dr. Doris Brown, and I want to welcome you to the second in a series of community health education programs. This is sponsored by Project Impact. Impact means increasing minority participation in clinical trials. This is part of the National Medical Association in partnership with the W. Montague Cobb and a whole list of community agencies and friends. I will tell you who they are later on, but we know health is truly wealth. If you are not healthy, you are really losing money at the bank. And so this afternoon, we are going to bring you a dynamic panel of diverse individuals who's going to tell it like it is. So we want you to ask questions, to be engaged, because this is about you staying healthy and being wealthy, because physically and mentally, you are on with it. So I don't know how to sing and dance and all of that, but I'm going to bring Deacon Donnie Evans. I'm just meeting most of my people here in Houston because I am not from Houston, but we have good friends because my undergraduate college is well represented. And of course, the Medical Association is well represented. My medical school is well represented. So I'm with family this afternoon, but we're going to start by having Deacon Donnie Evans give us an invocation.
Thank you, Dr. Brown. Let us go to God in prayer. During difficult times and uncertain seasons, we are implored not to lean into our own understanding. So God, we thank you for this assembly of faithful servants you've given us. Give them willing hearts and willing minds to do the task you've laid to their hands. We thank you for this assembly. We thank you for the progress that's going to be made from the words that we hear. Let our hearts receive them in the way that we want to hear it. God, we invite you into this space so that you can propel this program and propagate its purpose throughout the nation. In the name of Jesus, we pray. Amen.
And now this dynamic panel is going to be moderated by a friend and colleague, Dr. Gary Shepard, who has managed the National Medical Association along with me on many things. And so again, I will give it to him. He is one of the esteemed physicians here in Houston. So I know you're in good hands if you're looking for a physician, primary care. So I'm going to turn this over to Dr. Shepard.
Thank you, Dr. Brown. Hello, everyone. My name is Gary Shepard, and as Dr. Brown said, I'm an internal medicine physician here in Houston. I've been in practice for a little over 30 years. It doesn't seem that long, but it is. I am that old. I have had the privilege of actually being able to moderate this session. We hope that you will be able to learn some things on a number of different topics from the panel today. Also, I encourage you to start thinking of questions you would like to ask. We have a number of people who are represented here, and I'll introduce them. But please consider writing down some questions and actually be able to scan it. Also, there's some a QR code on your seats, so you can use that, and actually will bring up the full bios of everyone and the program. But please start thinking of questions you may have to ask the panel. We do want to make sure we give you plenty of time to have questions and answers. I'm going to go ahead and introduce the members of the panel. And we moved around a little bit here. So I will have to jump around to be able to introduce everybody. But on my far left is Cynthia Blanton Brown. She's an RN, and she's the current president of Black Nurses Association of Greater Houston. She's a retired registered nurse, having retired from MD Anderson Cancer Center after 26 years of service as a research nurse and a research nurse supervisor. She earned her LVN license from Houston Community College, her assistant nursing from Alvin Community College, and her BSN in nursing from American Sentinel University in Colorado. She is a native Houstonian. Not many of us, but there's some of us still left. She wants to make sure that people know that she is a blessed mother and grandmother. So we're glad to have her here as part of our panel. Next person to my immediate left is Dr. Napoleon Higgins. He is the current president, the executive director of the Black Psychiatrists of America and CEO of Global Health. He's a child, adolescent, and adult psychiatrist in Houston, Texas, and he's the owner of Bay Point Behavioral Health Services. He's an author and co-author of multiple books on ADHD, depression, and grief, Black mental health, and physician practice issues. And he also specializes in nutrition and health to improve patients' lives mentally and physically. Sitting to my immediate right is Dr. Raymond Little. He's the founder of Houston Heart and Vascular Associates. He's a distinguished physician, entrepreneur, and community leader with nearly 30 years of experience in the field of cardiovascular medicine. And he's the founder of Houston Heart and Vascular Associates. He earned his Doctor of Medicine degree from Boston University, where he also completed his internship and residency in internal medicine. He went on to complete a fellowship in cardiovascular medicine at Georgetown University in DC, and he received advanced interventional cardiology training at Baylor University Medical Center in Dallas. In addition to his medical expertise, he also holds a master's degree in finance. So if you have any money questions, he's going to be the one to ask, from Boston University. He has devoted his career to improving heart health outcomes, mentoring aspiring medical professions, and advocating for health equity in underserved communities. That's Dr. Little. The next person in line is, here we go, Dr. Lanzetta Newman. She's a professor of medicine in the Department of Clinical Cancer Preventive Division of Cancer Prevention and Population Science at MD Anderson. She's a board certified internist, and her clinical duties basically are in cancer prevention center in the undiagnosed breast clinic. In each area, she's committed to a multidisciplinary approach to assisting patients and their families. She exemplifies excellence in the practice of medicine and was elected to fellowship in American College of Physicians, the national organization for internists. She serves as a volunteer faculty of UT Health Science Center here at Houston, or McGovern Health Science Center. And she also is a preceptor of future physicians, both through the medical school and via the statewide General Internal Medicine Preceptorship Program sponsored by Texas Medical Association. She not only educates medical students, she extends the knowledge to a host of other clinical providers in training, including advanced nurse practitioners, residents, and fellows. She helps achieve the mission of making cancer history by serving on a number of institutional committees, which includes the National Cancer Expansion Steering Committee and Credentialing Committee for her medical staff at MD Anderson. As an institutional ambassador, she actively communicates with MD Anderson Cancer Center's research, science, clinical endeavors to the community. And last but definitely not least, all the way to my right is Micheline Holmes. She's a cancer survivor celebrating a decade in her survivorship. She's a mother of 2 adult children and a program manager for infectious diseases at MD Anderson. She was diagnosed with breast cancer in 2014 at the age of 45 when she noticed a tightening in her left breast. She has what we call triple negative, and I'll actually let her explain a little bit more about that as we go through. And despite her initial fears and a BRCA2 genetic mutation diagnosis, which increased her risk for breast and ovarian cancer, Micheline persevered with treatment. guiding 3 of her sisters and her father, who also tested positive for the BRCA2 gene. She has successfully assisted them with navigating the prevention process. She offers a one-on-one assistance to cancer patients and caregivers through MD Anderson's Cancer Connection volunteer program, the Halo House, which is stem cell transplantation patients, Can Care, providing one-on-one support to newly diagnosed patients. She has a conscientious effort by participating in cancer research, and to date has participated in 14 research programs to eradicate breast cancer. So can we give a hand to all the members of the panel? So I'm going to give each of the panelists opportunity to sort of give a highlight of some of the things that they do and just some background. Then we'll go into questions after that. So we're going to start with Ms. Brown.
Good evening. Thank you all for coming out. So since I've retired, I have done some home health. I've worked with home health agencies and quite a few. And also, I'm a member of the Black Nurses Association, and that's given me the opportunity to still interact with the patients. And what I keep hearing over and over again is we have non-compliance with diabetes and hypertension. That's big in our community, and that's a concern. We have the patients with the type 1 diabetes where, you know, they're insulin dependent. They seem to be okay. It's the type 2 diagnosis that say, you know, they've been diagnosed later, they don't believe it. They take their medicine sometimes they don't take their medicines. It's just many, many excuses. And of course, it's an issue with trying to get on a certain diet, and the diets have changed now. It's not like the old diabetic diets. It's getting on a certain diet, exercising, and watching your weight, smoking, and less alcohol. That seems to be an issue with the type 2 diabetes patients for being non-compliant. And then with the hypertension is huge as well. The patients get an understanding. You try to explain to them about the pressure in the arteries and the difference that's going on and what's happening with the when the pressure is high. It's literally pressure, and it's causing your arteries to change, and that's the issue in the end. But patients still say they don't like the way the medication make them feel. It's an issue. Or I'll take my medication today, but not tomorrow because I have an event. I want to drink or whatever. You know, it's just different excuses of why we won't take our medicines. And that's the issue. Then you circle around with the diabetes and the hypertension, and the next thing you know, they're in the dialysis clinics. And we have over 100 centers here in the Houston area, and they stay full, and it's no reason. So I guess what I'm saying today is what we need to work on is I'm sure everybody in their family have someone with diabetes, hypertension, and possibly that goes to the dialysis clinic. What can we do to help? And it's just educating one another. Everything, it's out there for you. They have it in the clinics, in your different clinics in your area, multi-purpose centers. It's information there, free information. And the health fairs that are being put on now, the health fairs are not well attended unless you have given away something free. Well, good health is free. And that's what we just need to, as families, pass around when we talk about different things, the game, like the game tonight, that's a big deal. Let's talk about our health at the dinner table, even while we're around the game, just sneak it in there somewhere. Have you heard about this? Do you know this? And if we could just get that's where I am with it. Just trying to see if we can help one another by educate and prevention. If we prevent it and catch it in the beginning when it's pre-diabetes, because when we get to the doctor and talk about pre-diabetes, and the doctor send you home and say, okay, you know, you better watch it because, you know, you're getting there. I think that if we could just start right there at pre-diabetes and jump on it then harder, right then they won't even get into the type 2. At least you know that you've done everything. I'm gonna stop. Okay. Thank you for listening.
Thank you. I did fail to welcome the internet audience. We're being streamed on blackdoctors.org. So we do want to welcome those people who are around the country and probably around the nation, around the world, who are watching this. And even though we're doing this in Houston, the information we're going to give you actually would apply anywhere, no matter where you are. Dr. Higgins.
Yes, it's great to be here, and I'm thankful to be invited and be at such a wonderful event. My name is Dr. Napoleon Higgins. I am from the Houston area, grew up right down the street. I remember when this building was built, and I'm like, yo, it's been here a long time, man. It's been here a long time. But it's always great to hang out and talk a little bit about mental health. So I'm in private practice, child, adolescent, adult psychiatrist. Been in practice for over 20 plus years now. And, dealing with, mental health in the Black community is something that I always love talking about because we don't talk about it enough. I do notice that the conversation is a bit more now in the last, say, 5-10 years. I would say especially so in the last 5 months. And why is that? And that's looking at the issues of the struggle that we've been through from our current days, but also back to our ancestors and how we came to be in this country and the stresses and the struggles that we've been under, understanding that, in our current situation, we're in quite a familiar place, which is the stress of being Black in our country. And so when you look at our overall health is poor and our overall mental health is poor than the average American. And so right now it's time for us to start talking about it. This issue of lack of knowledge of mental health and that it happens in the Black community is something that we continue to struggle with. I continually have people who say you should not see a psychiatrist. You should not take medication. There's no need to see a therapist. Well, if you believe Jesus, you wouldn't need any help. And all these things go on, realizing that mental health is in the Bible. And Jesus said he came as a physician. He didn't come as a beekeeper. He didn't come as, other things. He went to the people to do work on the people. And that is your mental and your physical health. So understanding that one thing I try to stress to Black people is this, that psychiatry, we've kind of thrown off the definition. When people think about psychiatry, they think about mental health treatment. But psychos is the spirit, the wind, and iatry is the treatment of the spirit or wind. And some of that may require church. Some of that requires Jesus. Some of that requires getting a good night's sleep. Some of that requires putting down the alcohol, putting down whatever you inhaling into your body. Some of that spirit of wind treatment is looking at the type of friends that you have and the lifestyle that you have. But sometimes that is actually seeing the doctor. And I tell people there are certain things that will occur that can occur in your mind where your mind gets sick like any other part of your body does. And sometimes that requires a physician. So I tell a person, if you got a broken leg and a bone sticking out, I would not recommend that you go walk that off. All right. I also wouldn't recommend you call your pastor. All right. Now, you may want to go to Jesus because you want to stop whatever just happened and you don't want to do that again. But sometimes you need to get that bone set by an actual doctor. And oddly enough, sometimes I'm literally setting bones in your brain. You can try to walk that off if you want to, and you can try to pray it out if you want to. But God made all of us to help one another. And trust me, sometimes you need to come and see a psychiatrist. Thank you.
Thank you. I think this is a Sunday, and this is the first Sunday, so I think we're going to have a little bit of church here.
Yeah.
As a church trustee at my church, we will be passing the plate, just so everybody knows. All right. I'm sworn to say that. But one of the things that Dr. Higgins mentioned seriously is that unfortunately mental health has a bad rap, and people don't realize it's still a health problem. It's a disease, and it has to be worked on. And when people say that, well, I can just pray, yes, but you don't know what God's plans are. We don't know who he will put in your way to actually help you. So you can't limit him by saying, all I have to do is pray and it can be taken care of. He may be putting a doctor in your way in order to help you. So never limit God. Next, Dr. Little.
So thank you for inviting me. It's an honor to be here. I want to start by echoing what Dr. Higgins mentioned. I think you're right. The whole notion of psychiatry and mental health, we need to upgrade it. I call it the whole self. So when I'm talking to patients about their cardiovascular disease, how they're feeling and doing mentally is a major part of that, how they deal with stress. My background, as you heard, has been in cardiovascular medicine for nearly 3 decades, and I've played a role at every step of the way. I got recruited to come here to treat heart attacks in the middle of the night when people have sudden death. And I realized that I was playing a role too far down in the pathway. So I refocused myself on prevention, because I don't want to see you in the middle of the night. I want to see you in the office talking about how you're getting on with life. And part of that is your cardiovascular health. Cardiovascular disease kills more Americans than any other disease, more than cancer and AIDS combined. Every year, there's another 800,000 people that die, which averages about 30 to 35 seconds. Some American has a heart attack or cardiovascular disease. And, as my good colleague, our nurse, mentioned, that all those risk factors, the blood pressure, the cholesterol, the diabetes, are all things that, cause the arteries to become damaged. Particularly in our community, we know that African Americans have a 50% greater likelihood of having hypertensive related complications, a 30% likelihood of having diabetes complications, and a lot of the stuff we don't talk about in terms of the, being healthy. And, we want to redefine what health is for a particular, individual, but we really ought to be talking about how our whole community needs to get healthier. And I could cite all the statistics. You guys heard I'm a number guy, but I think that the future is for you becoming a master of you, right? You have to explore your whole self. And that may mean how you feel emotionally. We know that increased stress worsens hypertension and makes it more difficult for us as clinicians to manage hypertension. And we see all the complications like the dialysis centers and the loss of limbs. We set up our practice to save the hearts and legs of Texans and eventually all Americans and maybe the world. So we have a big picture vision, but we think that the effort to change the trajectory of your family and of the statistics is that you become a master of you, and to experience your whole self. Not only do you need your blood pressure better, but you need to be able to be aware of the triggers of your stressors. And there's all these other social determinants of health that I'm sure Dr. Shepard deals with every day. People with access to care, access to specialists, access to generalists. In our community, it's not as high as the American community in general. We also know that there is a less of a likelihood for us to adopt prevention. And I think that's the key. We got a lot of wonderful medicines. We got a lot of wonderful tests, MRIs, CAT scans, PET scans, balloons, stents. None of them are more powerful than you. So that's my message.
Thank you. Next person to speak is Dr. Newman.
Hi, I'm Dr. Lanzetta Newman. I am a professor of medicine at the ¡1 cancer center in the world. Why is that important and why should you care? That is in your backyard. Why would you seek care anywhere else when you can have the best? I think I'm going to piggyback on prevention, not getting the disease, or if you do get the disease, how can we detect it early such that you have a great outcome both now and long term? So 3 things I wanted everybody to take home today about some of the services we provide in preventing cancer include screening. Know your screening guidelines. We want women at a certain age to get a mammogram every year, not every 2 years. I want to emphasize that because African Americans have been quoted to get breast cancer in particular less likely, but when we get it, we're more likely to die. Statistics, okay? We don't have to have that destiny. We can prevent certain things by changing what we eat, what we drink, knowing your family history. That is very important. When we're around the table, as you have heard, or every year at the family reunion, we must focus on the health beat, meaning what did the people, our ancestors, die from? What age were they? And did anybody have any mutations, et cetera, that might help the next generation? And we can offset some of these things or detect them early. One other thing I wanted to plug, at MD Anderson, you do not have to have cancer. If your family history suggests that your risk might be elevated from the general population, seek us. We have included in the QR code for prevention services and how might we help assist you further. Other services that we provide include the undiagnosed breast clinic. Why is this important? We can take you from having a problem, a breast lump today, get a diagnostic mammogram, ultrasound, and biopsy in one day, and at the end of that day, review all those results and develop a tentative plan. That is important for us to expedite your care so you can have the most optimal outcome in the end for you and your family. So I think it is most important for you to emphasize all of these points to your family. And one last point, if you ever have a biopsy of anything, your skin, your breast, your toe, I think you always need to obtain a copy of the report. That is essential to carrying your pathology reports along as you go. And if you move, there are so many instances where people who look like us say, my biopsy was benign. And then when we look at the report, it is not benign, meaning you have some elevated risk factors whereby taking some medicine might help prevent breast cancer. And we can monitor you with all the fancy tools a little bit more frequently. So do not deprive yourself of all the things that are out there that can help make a difference in your life and your family's lives. And I'll stop and take on more questions later.
Thank you. One of the things I would like to piggyback on something she said, she mentioned breast cancer. For men, prostate cancer, same thing in the African American community. Your screening starts at age 40, not at age 50. Or if you have a first degree relative, which includes your father, grandfather even, brother, if they have been diagnosed with cancer in their 40s, you need to move back 10 years earlier than their diagnosis to start your screening. So, and the reason for African Americans to start early is because we have cancers early and they're more aggressive. So this isn't something, well, I can maybe wait every other year. I can wait until I'm 50, or, well, you know, you really don't have to do the rectal exam, just do the PSA. No, because we miss diagnosis when we do that. And for us, it's really important to make sure that you are diagnosed early, because your survivorship is a lot better when you're diagnosed early, you're found early, treated early, instead of waiting to the last minute. So like I said, same thing for breast cancer.
Can I say one thing about the prostate? Since Gary brought that up, it is the digital rectal exam with your PSA. Many men have a normal PSA in our community, and the exam is abnormal, such that we need both of those things together if we are going to prevent or get a diagnosis at an early stage.
And please tell your friends, whether you're in the barbershop, you're out on the basketball court, to get both, okay? I have to work really hard sometimes to convince a person that, no, we got to do this. Well, I thought all I had to do was get the blood test. No, we need to do both because I need to catch this early, not late. So this is one of the things you tell everybody, like I said, at the family reunion, as you said, making sure all of the men know that this is something they need to get done. They can't skip it to make sure they get that done.
Certainly. And then to echo Dr. Shepard's point, a lot of men think that if they get the PSA, they're going to get some info that they don't want. And there's that notion of active surveillance, and we can keep an eye on things, but it has to start with you becoming a master of you. And you've got to know what you're at risk for and be intentional about answering that question so that you still have the power of choice.
Now we're going to have a little bit of a different perspective for a person who survived cancer. Micheline.
Hi.
Hi.
So I'm from Philadelphia, not
Oh.
Houston.
Okay. All right. Germantown.
Yes.
Germantown, Mount Airy. Okay.
Yes. Yes. I went to Germantown High School.
Did you? So
I did.
Oh boy.
So I was diagnosed with triple negative stage 3 breast cancer. And it is one of the leading breast cancers for African American women. And it is a fast growing tumor and it's aggressive, right? But mine was genetic. My father's side of the family were dying off of cancer and nobody said anything. So I want to talk to the community about, one, you cannot do cancer alone, and that if you share a bloodline, you need to tell somebody, right? You can't be in secret and saying that Paw died and you don't want to tell the children why, right? So I am a product of that. No one said anything. And so I was diagnosed. I had a double mastectomy. I had reconstructive surgery. I had to also have my ovaries and fallopian tubes removed because of the gene for preventative care. So I've gone through all of that surgery and everything else and stuff. And I know that because I'm sitting on the stage right now, I don't look like what I've been through. But I've also, thank you very much. Thank you. But I want to say that when I met my oncologist and when we first started the progress of starting chemotherapy, one of the things he said to me was that Black women do not participate in research. And so what he had to do was use the data that he had of a Caucasian woman for me. And I told him he was never going to have to tell another Black woman after me that we don't participate in research. So I participated in 13, 14 research studies, clinical trials after that. And then I began to tell my father's side of the family that we have a genetic mutating gene that was cancerous and that we needed to go get tested. It's just a blood draw, right? I understand that in our community, what they did to us in past, but it's just a blood draw. And men can get breast cancer too, right? So with my father, I said to him, you have to go and get tested because we have this gene. You can get breast cancer too, prostate cancer, pancreatic cancer. So my dad and 4 of his daughters tested positive, but I was the only one that was diagnosed. So I took it on to tell them. One of my sisters lives in Delaware. MD Anderson has a hospital in New Jersey. And I called New Jersey and told her my sister was coming and she in Delaware and that she needs to be seen. So she is now, in preventative care, getting her breast removed and doing those types of things. She's already past having children and all of that, right? So we're trying to now send a message to our children, our grandchildren, our great-grandchildren that we have a gene on our side of the family and that we're not going to be quiet about it anymore. So I want to say this to the community that we have to start talking about things. We have to participate in research so that we can eradicate this. What you're looking at today is I'm making cancer history, right?
Amen.
That cancer is not a death sentence. You looking at me, I was stage 3, right? And once he told me that, I said, well, how many stages are it? You're like, how many stages? And he said, it's 4. And I'm like, what? What do you mean? My daughter was 16 years old, right? And so I knew that my daughter could not live without me, so I had to do something about it. And so because I was at MD Anderson, and MD Anderson doesn't make us say that they're number one and that they're the best and everything else stuff. They are good at what they do. And so I stand before you today saying that we have to communicate with each other. We have to tell. If we share a bloodline, we have to communicate and say, this is what it was. I sent my information for my genetic test to my siblings and to my family. All they had to do was take it to their insurance, say that I have a sibling that had breast cancer, and all they got a blood draw with no questions asked. So that's what I wanted to share with you guys today.
Thank you. It always helps when you actually have a person who has experienced this and you can hear from them firsthand of exactly what to do. And it's really important to make sure when you have something like BRCA in your family to share that, as she said, to make sure that your family know this. Unfortunately, we have a history of not sharing. It's like, well, grandma died of something, but they didn't tell me about it and they didn't talk about it. And so do the parents know now? Well, I'm not sure. No, I encourage people to always find out what exactly is in your family, because it can affect you, it can affect your siblings, it can affect your children. So it's really important to share that. Once going back to the whole idea of the family reunion, at the family reunion, you yourself can organize something to have people learn what diseases do we have in our family. Okay, that's something you can do while you're registering, while you're playing games, while people are talking smack because they play in spades, whatever it is, or bid, even worse, whatever it is, have that health questionnaire, okay, of what diseases do we have in our family that will help us as we progress. Okay? So everybody's given sort of an introduction. Wanted to actually go to see if anybody has any questions right now. If not, we're going to ask some other questions that we have. Does anybody have any questions currently on what you've heard so far? Yes. Oh, he has a mic.
Oh, hello. Hello, thank you. My question is, I noticed that you all talked about the different forms of disease processes and what you're doing for them, but as a nurse, I find that literacy also plays a great big part in what you all are teaching. I'm an educator now with population health. So most of the time, I say 90% of the time, the people go into the physician's office, and myself, because when I'm a nurse, when I go to the doctor, I don't know nothing. You know what you're talking about, but there's a great deal when I work with Medicaid that we had to bring everything down to a 6th grade level in order for people to understand. So I think that is a huge impact and missing point that is being provided to the community. And it just gets, and because we are a proud community, we never tell a doctor, I don't know what you said, but yes, sir, or no, yes, ma'am. And then they walk out of the office and I'm not taking that. That's it. Thank you.
Yeah, Dr. Little he's waiting to talk about that.
Yeah. So you make a very good point, and I call it just plain English. But you're right; it is not taught in schools, right? Doctors are not taught how to talk to regular people about regular stuff. There's no class in it. It's more of an art form these days. The good doctors understand. And I do a lot of clinical trials, community-based, decentralized trials. In fact, we are part of the largest going forward or prospective study looking at cardiovascular outcomes in African Americans. It's called the African American Heart Study. And I tell folks what it's not. I say this is not any Tuskegee stuff. I use that term because I know that's what's in their mind. I said it's already been proven to be safe, but no one's looked at the outcome in us. And that is a plain way of describing something very complex, which has crazy molecules that somebody got a Nobel Prize for. But that's not the conversation that I need to have. And I always make sure that in addition to talking to the patient, I talk to whoever else is in the room, right? I'm talking to your wife or your son or your daughter. That's the person going to bring you to those visits. That's the person going to explain to everyone else in the family what's going on. So if I'm using big fancy doctor terms, I've already lost. So I think your point's a good one, that we have to be aware of just speaking plain, right? Like you're at a family reunion.
Oddly enough, I wrote a book, me and a team wrote a book called Mind Matters, a resource guide to psychiatry for Black communities. And it's written on a 6th grade level, all right? So it's available on Amazon. Just put in my name, Napoleon Higgins, and you'll be able to find it. Oddly enough, it was 10 Black psychiatrists who got together to write this book. And it covers all the major mental health diagnoses, including how the medications work, what the doctors want to ask you, what exactly we're looking for. It's not just random questions. We're trying to figure out what can we treat and what do we refer, all right? Understanding this, there's nothing in medicine where the doctor gives you a pill and it fixes anything. It all requires that you do your part.
Yep.
So when you see the doctor, it's 90% of what I do and 10% of what you did. But once you walk out the door, it's 90% what you do and 10% of what I did. Now, obviously, I can get a lot more done if I can communicate the information clearly to the patient of what's going on. The odd thing about writing that book, every line of that book has been rewritten at least 4 times. And the reason is, even though we were trying to speak in plain language, we learned medicine in a different language. And you speak it back in the language that you learned it. And oddly enough, mental health sounds very common when you use regular words. People will say, oh, that's what I have going on. Or that's what's going on with my child. Or that was my grandmother. Realizing mental health is more common than people would think. Behind primary care, which is internal medicine, family medicine, and pediatrics, the next most common doctor is a psychiatrist. Now, and then there's not enough of us, even at that. All right, so understanding that these are very, very common. You cannot get through life without something happening. There is going to be a medical condition that's going to impact you. People, when I was a kid, they say people kick the bucket or they drop dead or what happened. They kick the bucket, and I'm like, man, where's this bucket at? Because I'm going to avoid it as much as possible. But no, something happens that causes your demise. And what we're talking about today is actually saving lives through the education. But part of that is going to be the literacy, and that's explaining it. I wish that medical education was a part of regular education. There are parts of your brain that do certain things, and life impacts those parts of your brain, and it causes you to behave in a certain way. And it's really not even deep. If I stress you enough, yes, I can guarantee you're going to become depressed, hopeless or helpless, and even suicidal if I put that much on you. So you've got to recognize, when am I being stressed, identifying the stressors and getting that stress off. Understanding that whatever helps your mind helps your heart. Whatever helps your heart helps your mind. The two are one and the same. So we have to make sure that we're getting this information across to our people. And I appreciate you all showing up to hear it, but then also going out to spread the good news.
One of the things, I'll get you a minute, sir. One of the things when you talk about literacy and understanding, please, I encourage you, when you're in your doctor's visit or your parents or your children, if you didn't understand what the doctor says, don't pretend that you understood what the doctor said. Ask them, I don't understand that, explain it. People don't have as much of a problem if they're going to a lawyer and people are speaking in lawyerese. We're speaking in doctorese. But they'll say, what does that mean? But for some reason, they don't want to ask the doctor, I don't understand that. Please explain to me what you just said. Okay. And if we have a problem explaining it again, then that's on the doctor and want to look for somebody else probably, because we should be able to explain things a little bit better. Sometimes it takes us a couple of times because, once again, the way we think about things and how things are laid out. But I have to stop sometime and say, okay, that makes sense to me, but may not make sense to everybody. And you have to have a balance of not speaking down to people, but making sure people understand. So if you don't understand, ask them to explain it again in a little bit different way. That's because, as you said, it's all about your health, and you are responsible for your health, and that's one of the ways you do it. Dr. Newman?
I just wanted to add, part of the history taking that we do, we ask social history. What does the patient do? What are their hobbies? And I use that information to be able to have that discussion with the patient, such that you put it in terms that they are more familiar with, in an area in which there is some they are familiar as well, and you pick and choose words that will stick with that person. In addition, for breast, we talk about the breast all the time in terms of a clock. So everybody knows the time. We draw such that the patient can take that picture home with them. And, you know, at 2 a.m. when you have those questions, you still have this little diagram that you could look at, and that helps to jolt. And I agree, we're educating everybody, and I can't emphasize that more. If you do not understand, it is that doctor's job to help you understand. If you still feel uncomfortable, you need to find another doctor, another person, because like Micheline stated, you have to have a good relationship with your doctor such that that is part of your health. And if it's not there, seek others. There are plenty of us sitting on the stage. There are plenty of doctors in the community. Just get the help that you need for your personal health.
Another question?
Yes, several questions actually. To the psychiatrist, Dr.
Higgins.
How do you address having a drink until you're drunk before you go to sleep? That's one. What is the number for the PSA that has to be before you're actually diagnosed? And as a prostate cancer survivor myself, I've learned a lot. It opened up a whole new chapter of cancer, aside from the other cancers that are out there. A lot of times when I talk to men about prostate cancer, it's like trying to borrow money from them, or, you know, something to that effect. I'm like, dude, this is gonna help you. Is it automatically on your insurance and in your annual physical? So expound on those comments and questions that I've just put forth.
Okay. Go with you.
I'm gonna start with prostate cancer. I'm a psychiatrist though, all right? So take it with, I did go to med school one day, and I do have a prostate. One story that I was just told by a friend of mine, and the reason it's relevant to what you're saying is that it's 4 or below. It's between 1 and 4, I believe is the numbers. His was 1, 1.1, 1.2, climbed to 2, 2.4. His doctor said nothing to worry about. It's well below 4. He spoke to an oncology friend of his who said, no, you need to get that looked at. Turns out he had prostate cancer. All right. And it was less than 1 millimeter from the capsule of his prostate. All right.
Which is the covering of the prostate?
Yeah,
Yes,
on the edge.
The covering, and it
which
could get
you know,
metastasized.
Yeah, before it metastasizes. So when they talk about stage 1, stage 2, stage 3, stage 4, it's based upon location. So his warning to every black man is you need to have that number followed. You need to have that number looked at. And if it starts to climb, at that point, you don't wait for it to be a 4, because his good friend said, well, let's wait for it to get up to closer to 4 or above. And he was like, no, let me get this checked out. So he says that he definitely feels like it saved his life, or definitely prevented all the other outcomes that could have potentially occurred. Another friend of mine had a similar story that passed away about a year ago. The president-elect of the Association of Black Psychologists, close friend of mine over years. Same story. They waited. It was too late. Battled 5 years and had to have a whole host of things done to live that 5 years. That he says every man should be able to prevent that. Now, when it comes to if you drinking alcohol, substance abuse, if you're having to drink until you're drunk in order to pass out, you probably have 2 problems. One is a drinking problem, and that may be a mental health problem going on as well. One that is very dangerous if you've got to drink until you pass out, and I would consider that to be an emergency situation if you're not able to sleep. All right, so that is something that needs to be addressed. That could be mental health issue that is going on, or it could be a physical health issue that is going on. But it does require that you come in and see a doctor and get that handled quickly, because that could be that's a dangerous situation.
So when it comes to PSA, Dr. Higgins said it's not the absolute number. The way I explain it to my patients is the range is 0 to 4 is in the normal range, but it's not that static number. It's also what we call a delta, or the change from year to year. That's why you want to make sure you're getting your PSA checked every year. So for me, if you jump more than 0.8 from one year to another, some people say 0.5, then I'm going to take another test in probably about 6 weeks to 2 months. But then if it's still actually high, because sometimes the number can bump up because I did the exam, if you're getting your blood test on the same day. So I want to repeat it, but then I want to see if that's changed. No, this is definitely changed from last year. Then you're going to the urologist, because they're going to need to do an ultrasound. They'll need to decide if they need to do biopsy, if they need to do an MRI. But it's not only that number, it's that change from year to year. And that's what people have to remember. It's not the absolute number all the time, but it's also the change.
Is it on the annual physical?
So yes and no. Because once again, what the groups are saying sometimes is, oh, you don't have to start until age 50. And then it's more of a discussion with, and it's a discussion with your doctor whether or not you want to have it. When I'm talking to my patients, it's like, you need this. It's just like for my women, it's you need your mammogram. It's not, we really need this because, and then I explain why. Okay, I don't just say you need it, but it's the importance of it and why it makes a difference in our community. So we actually have to know how to code it in order for it to get paid. Unfortunately, if I don't put the correct code in there, then the insurance doesn't want to cover it, and they will revert the cost from the lab to the patient. I've got to make sure I put a code in there that says this is prostate cancer screening. If I don't put that in there, then the insurance doesn't want to cover it. So yeah, they make us jump through a little hoops in order to make sure it's done. But as a physician, I've got to know those things, and I've got to make sure that women get their breast screenings, men get their prostate screenings, everybody gets their colon screenings, and I have to make sure that I'm putting the right codes in order for the insurance to cover it. And yes, it should be on an annual physical, like I said, starting at age 40. It's like, okay, you're 40, we got to start doing this. And once again, I get pushback, but I explain why it's important to get that. Dr. Moon, you had a comment?
Yes. I agree with all you said about the screenings. We didn't talk about colon cancer screening. For us, that is 45. And a lot, like ACP, a couple of other colleges are making different recommendations. 45 for your colonoscopy, 40 for your prostate, 40 if you're average risk for breast cancer. But like Micheline mentioned, she had breast cancer at 44. Her daughter needs to start at 34, or the youngest age of the affected person in your family 10 years earlier. If the whole goal is prevention and early detection. There's stage zeros of cancer as well. So if you include stage 0 with stage 5 stages, you want to be at stage 0 or stage 1, where you have 98% or 95% survival. That is where nobody wants cancer, but that is where we want to be if we're going to get it.
Hold on a minute, sir, because we have another question and then we'll come back to you, okay?
What was the name of the mental health book that you had written?
Mind Matters, a resource guide to psychiatry for Black communities.
Yeah, your question, sir.
So should we pass a law or something, or do write insurance companies for for men of color to ensure that we address? I've worked with Dr. Curtis Petway.
Yes.
I've worked with Dr. Arthur Burnett at Johns Hopkins, where I had my surgery, and I've been educated, on this, and there's a lot to it. But so should we? Is there a way we could pass a law, or what do we have to do to make sure men like us get checked?
People. It's important for all of us to advocate, and that's what this is all about. We're trying to empower you to advocate for your rights. Yes, you have people that you elected to go to your government locally as well as nationally. Keep writing those letters, keep calling them, keep visiting them. Make a change.
The work that you're doing right now is saving lives. You don't have to be a doctor to save a life. So getting the word out. Another thing that I'll stress to Black people: try to find a Black doctor. Black people have much better outcomes when it comes to Black physicians. No matter how many, what discipline, what study, what diagnosis, if you have a Black doctor, you're more likely to live. And many studies show that it's 2 or 3 or 5 times more likely to live. Like, I was listening to a story about podiatrists. Like, if you see a Black podiatrist when you have a diabetic foot, you're 3 times more likely to keep your foot if the podiatrist was Black. And I look at all the Black people who have their legs cut off and things of that sort. And don't get me wrong, many times that's needed. But you're more likely to keep the leg if the person that looked at your foot was a Black person and you're a Black patient.
Yes, ma'am.
Hi, thank you so much for all this great information. My question goes to diet in the African American community. So maybe if each one of you could speak to diet and how that would help mental health, cardiac health, cancers. You know, in our community, we do a lot of things around food, right? Or holidays and big mamas cooking this and that and the other. And then some of us are just stress eaters and we eat our stress away, you know, mental health issues. So I'm just wondering if you could speak to that just a little bit.
Go ahead.
No, I was just going to say that our focus is to sugar, if less sugar and less salt. That's just a given. Pork, we don't have to eat like we did in the past. And fresh, they say we don't have the food deserts in our neighborhood, but that doesn't mean that you can't eat right, even if you have the canned food or you have the frozen vegetables, which are better than the cans. If you have the cans, you can also rinse you can rinse them prior to cooking. And and reading labels is important for us. So it's just a matter of, we have to have our own mind made up about ourselves, to look at ourselves. So it's just a matter of making up your mind that you want to eat better. Less sugar, less salt is my only recommendation.
I know that the doctors are going to come in and tell you what they learned and all that. Nothing, especially the heart doctor. But this is what I learned as a patient. Those barbecues that y'all like and that smoke that's on that meat is cancer causing. That bacon that y'all like is cancer causing. That lunch meat and all of that stuff, you have to read the labels that's on it. That styrofoam that you eat from, that y'all heat in the microwaves and all that other kind of stuff, that's cancer causing. I learned all of that, right? I made my daughter, we stopped drinking milk. Like, we stopped all of that. The sugar, I do eat candy and stuff, right? But the sugar, I don't eat as much. But the sugar, I had to stop that. I struggle with eating vegetables and fruit because it doesn't look right in the supermarket. Like, it's ginormous. And I don't know how it was grown. And I think that the people are lying when they say that it is organic. So I'm the one that paid the $8 eggs, right? Because I don't want to think about how the other eggs that come in that little pink and styrofoam. So I paid the $8 eggs because I know how much it costs for the first year to cure cancer. So I pay the $8 eggs. I go to the farmer's market and buy the fruits and vegetables and those types of things and stuff. But all of that other stuff that you guys eat, I don't eat out at the fast food restaurants. I cook at home. And I try to watch the things that I eat, but I also read the labels. I was in a clinical trials for breast cancer patients, and it was a book, My Cancer Life by Lorenzo Cohen, who was at MD Anderson. And he taught me so much about reading the labels, about the sodium. It needs to be 500 or less if you get in the frozen foods. So I really stay away from those types of foods and things. But when it comes to like the hot dogs and bacon and all those types of things and stuff, it's cancer causing. So I don't know what triggered the cancer the first time, but I don't want to go through it again. So I just try to stay away from all of those types of things.
So just, can I comment?
Okay.
Yeah, so just to comment on the question about diet and what we should eat, there's certain things that we know are absolute, right? So patients who are focused on vegan, raw vegan, have fewer inflammatory incidents than those who don't. So raw vegans are those who have decided that they will not eat even cooked food. They're strictly raw. So the next level would be your regular vegan, right? And then after that, we have what we call plant-forward eating. Plant-forward eating, where the primary foods on your plate are plants. So it's not sodium, it's not processed, it's not ultra processed. Ultra processed are the chips. I call them the C's. The chips, the cookies, the creams, the cereals, the cakes, the candies. Those are the ones that will get you every time. Those are the bad C's. The good C's are your colorful vegetables, your cruciferous vegetables, and those that have grains. So there's a new movement, and hopefully it will catch on, and that is to start looking at plant-forward eating, where your main plate is vegetables, and you may garnish it with a protein. And the protein, the best proteins are still plant-based. The second best proteins are going to be your light fish. Of course, the worst is going to be your pork and your beef. But those have been proven to be inflammatory agents. The inflammatory agents, they inflame things, and that's what leads to cancer. So
I would say, oddly enough, what everyone has said is very true. And it's very difficult to eat healthy in our society. So essentially, we're back to being hunters gatherers, where good foods are not plentiful. So the majority of the food is going to be that it's in an African American diet is meat, or you also, now we're having some issues with vegetables as well. If you knew the extent to which they are manipulating the food, it's extremely scary. You almost run out of what to eat. All right. The reason it's hard to eat vegetables, well, I grew up in the country. Well, I kind of grew up in the country. I kind of grew up in Alameda Plaza in Sunnyside. But when grandma would pick food and we would eat it, lima beans tasted different than navy beans that tasted different than butter beans. Mustard greens taste different than collard greens that tasted different from the next green. So the food was so pungent and so flavorful that you could eat vegetables. But now when you try to eat vegetables, you feel like you're chewing on nothing. I was trying to eat a melon the other day, and I don't taste any melon. It tastes like cardboard. Why is that? They're crossing chromosomes and all that kind of stuff, which makes the melon actually crossing a lot of stuff with corn, which you're trying to avoid carbs, but your strawberries are now crossed with corn. The strawberries aren't juicy anymore, and they got holes in the middle. They're open in the middle, and they're very dry because they're crossing these things with carbs. So the problem is we're back to being hunter-gatherers. Oddly enough, you look at old-time eating, in the 40s and 50s, Black people had the longest life expectancy in America. So what they actually ate is something very different than what we eat now. And they ate a lot of meat, all right, but they ate a lot of vegetables as well. But the problem is with what the meat is, over 90% of all beef and pork is going to be hormone. So whatever you ate today just got killed a week ago, and the hormones are still in it, and you're still consuming it. And when it comes to our fish, farm raised, which they're going to feed carbs to, all the chickens, they're going to be fed carbs and all that. So the safest thing at this point is going with the vegetable. And then fresh vegetables are frozen. Now, when those cans, understand this, if it's less than 0.049%, they don't have to list it on the label. They could put a million things in there that's less than 0.049%, and it will never be listed on the label. That could be a third of the can. All right, so read the labels. And I'm going to tell you right now, the best food has no labels. If it has a label, that's a question mark right there. But even when you look at that, if you look at our cereals, you talked about cereals, and I used to do some health and nutrition talks. I'm talking too long. I'm about to get cut off. All right. on the bag. There's a product called BHT, or there's a BCGT, or whatever it is. A guy who worked in the plant works with it. He says in order for us to be around this, we have to have basically on respirators and spacesuits. It takes us 1 hour to leave work when we have to deal with this chemical. Why is it in every cereal? About 90% of all cereals in America have it as a major ingredient. So the thing is that it's very difficult to eat well, but try to make the changes that you can. They have clearly shown that if you live in a community where it has more fast food than grocery stores, you're more likely to eat fast food. But if you got to pass multiple grocery stores getting to the fast food spot, you're more likely to cook your own food. So we have to get back to cooking like we used to. Home economics, things that we don't understand anymore. If I showed up at my grandmother's house, she would have food ready in 15 minutes. And a whole set of food ready in 15 minutes. But we don't know how to cook like that anymore. So we have to be very conscious about what's going on and realizing that you are actually under attack. They're trying to kill you. By way of their greed, they're trying to cut as many corners on the food as possible. And that is causing serious health consequences in our country, most likely affecting Black people.
One of the things I encourage is actually food preparation. So actually making sure you may have more time on the weekend than you do during the week. And people say, well, I come home from work, I still have to go to the kids because they have this, they have that, they have soccer, they have football, they have cheerleading, they have volleyball, all of these things they have. When we get home, it's easier just to be able to stop by a fast food place to get food. But if we think about, well, over the weekend, I have more time, I can prepare my family's meals for the week and then you can warm them up, which it can be done quicker, but not in styrofoam, mind you. But you can warm them up and that will help. So that's one of the things is you have to think of the long game instead of thinking of what am I going to do today? It's like, well, no, what I'm going to do for the week. It's changing our thinking, but it's healthier for us.
Let me add this, and I'm going to just show this to you all on the stage. All right, so I highly recommend going to the farmer's market. When you go to the farmer's market, they get the food before it goes to the grocery store. So when the grocery store gets it, they actually treat it to preserve it so it holds its color longer. I'm going to show the stage what I purchased at a local grocery store. I purchased lemons and limes. Me and my wife ate one the night before, and the next morning I saw this.
So while we're looking at his picture, I'm going to give a shout out to the Black Farmers Market in Sunnyside. Just what you just said, there is a movement and you have to get on board because it is great that all of these young innovators are starting to have their own farms, their crops, their gardens. And in Sunnyside, people who look just like you are doing that and they're pooling all of that together so you can go and buy fresh vegetables. So what I tell my patients, we've inverted the pyramid, like what you were taught in the 70s, right? So vegetables, fruits, nuts, seeds, fish. Everything that I did not say, those should be celebration foods. If other people in your family had their legs cut off, etc., and you continue to eat that same way, we must break all of these cycles. You have to eat differently. It will help. Inflammation increases your risk of cancer. It increases your risk of all of the other chronic diseases, diabetes, hypertension, and dyslipidemia. There is a movement. Look in your communities and you just have to make a change, a conscious effort that you want to be healthier.
And there's also a change when they talk about having your own garden. Okay, so having I'm trying to remember the name. It's basically like city garden. So actually they have places around the city that teach people how to grow gardens in like their backyards, in some of the pots in your house. So you may not have a huge big backyard or don't have a large farm, but they are teaching how to actually grow your own food. And then their communities, they have a community garden. so people can come in and actually, that's where you can plant your food. You may live in an apartment, so you can't plant anything. You can go there and plant that in the community garden. So there's options. But once again, people have to think about these things in order to do them. Dr. Brown, I think you had a couple of questions as we end, because I think we are time. Yeah, we're 10 minutes past our time,
But that's okay.
good discussion.
It's wonderful when you have good information, you keep giving it. So I'm going to go around the room and ask the panelists a question, one from everyone, because there are a couple of things that I think is also important. So for Micheline, what's the most significant insight or realization you gained following your diagnosis?
That cancer is not a death sentence, and that there is life after cancer, and that you can make a purpose out of what you thought was devastation and the end of life, right? So that's what I've done. I've made it a purpose.
Okay, Dr. Newman, we didn't talk about a cancer that's the #1 leading cause of death in men and women, and that's lung cancer. We now have screening for lung cancer. Can you just give a little bit on that? But as a corollary, because I'm an oncologist as well, and we now have dense breasts that they tell Black women, you have dense breasts and send you off. Speak about dense breasts and mammograms.
Okay. So the first part, lung cancer screening, 20 pack years history. If you are in the ages between 50 and 80 and you have quit smoking within the last 15 years or a current smoker. So what we do in our practice is pair your lung cancer screening, which is the CT scan, with your mammogram. So if you're coming in once a year for that, we try to get all the screenings done at the same time, so you don't have to have multiple visits. So that helps patients to ease that transition. The second part, density of breast tissue, hottest topic there is in breast. So one option you do have as a breast cancer survivor, if you have extremely dense or heterogeneous dense, you also qualify for annual breast MRI. So when you sit down with your doctor, we look at your mammogram report, we talk about that density. There's a whole spectrum in regards to density, and we talk about, would you benefit from adding an MRI to your schedule? Though there's no study to say do it the same time as mammography or every 6 months or alternate 6 months. We do it mammogram. If you're gonna have the mammogram in January, we have schedule the MRI in July. Why? Though there's no data to support this part, but in theory, if you are higher risk than the general population to develop a cancer, then by us having a strategy to alternate between the two, if you are to detect or develop a breast cancer, we should be able to detect that earlier. Again, going back to stage 0, stage 1, the early cancers. So talk to your doctor, ask if you qualify for breast MRI.
Dr. Little, we're getting newer technologies with cardiology and the interventions. There is, and when we talk about congestive heart failure, that we're not seeing it as much, but there's also a genetic permutation that is seen higher in Blacks. Can you speak about the ATTR?
Sure, for sure. So heart failure, huge topic, because we're used to thinking of cardiac disease as the artery problem, right? Or the plumbing problem. Well, heart failure is a pump problem. So the heart, as the pump, has to pump out blood to the rest of the body. No pump, everything else suffers, right? So we're used to thinking of weak squeeze, but you also have impaired relaxation. Either of those can be a problem. We're now seeing, and I've actually have a personal familiarity with this in my family. My father-in-law had probably the ATTR, couldn't get diagnosis early enough. In retrospect, had a bunch of signs of something called amyloid. It's a protein that is made in excess because of some genetic modification or alteration, and that infiltrates the heart. So it makes the heart relaxation impaired, and that increases the pressures in the heart and creates problems. Most doctors, they're only thinking of a straight pump problem. So you almost have to be that advocate to say, hey, should we be thinking about other things? And I think there's a lot of room to educate our folks in how to ask the doctor to think about other things, to broaden their scope. Because if you don't tell them to think about it, they're just going to go, well, statistically, that's less common, and I don't see that. And then they're going to discount stuff that they shouldn't. So there is a genetic test, and the algorithm is kind of complex. They have to exclude a couple of things, but the important thing is that there's a form of amyloid that now has a FDA-approved medicine that improves outcomes and improves survival. But if you never even think about it, you didn't even have that discussion. So I would say discussions about not only artery, plumbing problems, but also pump problems should be front and center when you talk to your generalist and your cardiologist, because that's the whole picture.
Okay, Dr. Shepherd, you've been an excellent job in moderating everything. I have a couple of questions for you. And also because you brought it up in terms of those codes that we have to make sure that you're going to get paid. Those screening tests that we get, sometimes they want it to be a diagnostic, but you're not going to get paid. So you have to say, this is a screening mammogram. This is a CT scan for the lung. It's a screening test. And so again, how would a healthcare provider maneuver the system to make sure that the patient is not unduly charged for things that is not their fault?
First of all, as I said, when it comes to screening, so there are codes for prostate cancer screening. There's codes for breast cancer screening. There's codes for colon cancer screening. There's also a code for lung cancer screening. So we have to make sure that we're utilizing those codes. Unfortunately, the problem is once we get a screening, we find something, then it switches over to diagnostic. And that means that you will have a copay, or you may have to actually reach your deductible. What we're doing in the Texas Medical Association is our House of Delegates, which actually take it to the American Medical Association, to say insurances need to cover not only the screening, but also the next step. Because there's some people who say, well, I can get screened. I can't afford anything else, so I'm just not going to get screened. And we don't want to, once again, as you said, the cost of having a cancer is a lot more than the cost that you would spend in paying for this diagnostic test. Okay, so what we've said in the TMA House of Delegates, and it's gone to the AMA House of Delegates, is that we are pressuring the insurance companies to actually say that you need to also cover for these tests. So when it comes to prostate cancer, if you have a prostate cancer, your PSA or a rectal exam is abnormal, then you need to cover for that ultrasound also. Okay. If you have a abnormal mammogram, you need to cover also for that ultrasound or the MRI of the breast. If you have a colonoscopy and you find a polyp, then all of a sudden they said, oh, well, that's diagnostic. It's no longer covered as a screening thing because they had to take out a polyp. That needs to be covered. Okay, so that's what we're working on, to try and have things covered for the patients, because that's just as important. If they're not have that coverage for the actually trying to diagnose something, then we really need to push for that also. So that's sort of how we do that.
Okay. Hi, Doc. You brought up the statement about Black patients going to Black doctors do better. And they definitely, we have data to say concordance of care and patient better outcomes. So given that, would you recommend participating in clinical trials so that we can gain the data to have in our journals to know that, yes, this is going to speak to so-and-so participated in a clinical study and the outcome shows it is important. Can you address clinical trials participation? And
Sure.
particularly as it relates to mental health?
Definitely. I do clinical trials as well. I was a part of the first Project Impact. It wasn't called 1.0, it's called 2.0 now. It was just Project Impact. That was, oh my goodness, 15 years ago. And so I probably have one of the largest Black clinical trials, mental health, uh, um, work that we do. So it's really important because so often we're left out. As we had talked about earlier, a lot of this numbers and this data is based upon white people, not the stressors that Black people go through in America. So overall stress to the system increases the risk of every health disorder. So realizing that we're under pressure in our country, and we've been that way for a very long time, and it doesn't seem like it's letting up. I think it's really squeezing down. So it's important that we're a part of these things and that we not run from it. Now, I remember a recent clinical trial where it was 90, I think it was 92%. It was 92% white. Then I looked at the amount of people that I gave to the trial, and about 80% of the people of color came out of my one office. And this was a nationwide trial. All those people came out of my office. So it's very important that we're a part of these, that we become a part of them. I will mention that right now we're doing open enrollment for Alzheimer's trial. And there is a new Alzheimer's test that can diagnose Alzheimer's at a very early stage. And it can tell you whether it's Alzheimer's dementia or a different type of dementia. So it's either Alzheimer's or it's not. So we're trying to do that. We want to make sure that people know. We're trying to get more Black doctors involved in clinical trials. And when it comes to concordance, Black patients do better with Black doctors. Oddly enough, though, when it comes to racial concordance, white patients with Black doctors do as well as white patients with white doctors. It's only the Black part that causes you to do poorly. All right. So when we talk about concordance, it's only with Black folk. Everybody else doing just fine with Black doctors. So when it comes to racism, for some reason, we're able to see past race and treat the patient, but realizing that some people don't care unconsciously, but I think some people are actually trying to kill you. They don't mind you dying. And they're a part of the system that helps to get it done. Some things that we see are so egregious, that it couldn't have been by accident that you missed that. All right. Now, I think you were in on it. And you never know who it was. Part of my issue with having my prostate checked is that I just got another story the other day where they said, well, because your PSA was normal, you don't need it for every other 2 years. I switched 3 doctors trying to get a prostate exam. I had to go to 3 doctors trying to get a prostate exam, and I have a family history of prostate cancer. And so now I'm looking for another doctor. And so I've identified somebody else. But literally, you're getting bad information from people who said, no, you don't need that.
Okay. Well, Ms. Brown, I know that you do something in infectious diseases. We didn't talk about that. That's not your area. I want to ask you about patient education, particularly when we're talking about diabetes, and everybody is pre-diabetic nowadays because we've been eating all that bad stuff that we talk about in a rib every now and then, So when you're trying to educate the patient who's coming in and the glucose is 300, they didn't have a primary care doctor, so they went to acute care clinic. It's been up and down. And maybe they were on, I want to try this because I want to get thin, so I'm going to get a little GLP-1. But the GLP-1 doesn't seem to be working because they're gaining weight and the glucose is going up. And I know Dr. Shepard might want to help you in answering this, but what kind of educational program, because one, it's going to be diet and exercise and all of the kind of lifestyle things that's important for them. So you get to.
I don't know a lot about the GLP programs, but as far as education, I always try to send the patients. First of all, I see what they came home with the directions that they got from most of the time I see patients in home health, they've just been discharged. So I look at their discharge and I try to send them back to the physician that gave them the instructions. And also I sometimes I carry in my bag information that I get from the healthcare clinics, and I try to direct them there. And each week when I see them, or twice a week when I see them, go over and see what they've eaten. And I always try to encourage the patients to keep a chart, keep a diary of their diet and what's going on, and to watch and see how the sugar is fluctuating.
When it comes to diabetes and care for diabetes, it's an individual thing. And you can use some generalities of, well, we'll try this first or the next step. But the ADA, also the clinical endocrinologist, they've gone away from saying it's a stepwise fashion for physicians now. So it's an individualized fashion. So you choose the best initial medication that's best for that patient. So you have to look at what is their weight, where are their sugars, what's their fasting sugars, what's their 2 hours after numbers. So it's not just one thing. GLP-1s can be beneficial to a lot of people, but not everybody. They're beneficial because not only can they help with sugar, they can also help with weight, they can also help with heart, they can help with kidney. So they have all these benefits, but is it for everybody? Oh, so okay, so mental issues, yeah. So, but is it right for everyone? No. So it has to be an individualized thing. So this person, you said that they're 300 and they are on a GLP-1. It may not be the right dose because they haven't titrated it up yet, but that person also may need insulin in order to get their sugar down. There's a thing called insulin toxicity, which means the insulin itself causes a problem with getting the sugar down and also helping you get under your control. So I've got to get that sugar down. So there's sometimes I have to start people on insulin. They may be able to come off of it later. They may have to stay on it. And unfortunately, that's one of those things of what we talked about at the family reunion, because everybody says, well, no, because at the time my cousin, Lil John or somebody started on insulin, they had their foot cut off. It's like, that's because they should have started a lot earlier. Okay, so that's a discussion I have to have. But sometimes insulin is the right medication for you to start, and you may be able to get off of it. But at this point, that's what you really need in order to get your sugars under control.
If we could give a round of applause for a fantastic panelists. In addition to these wonderful individuals that are very dynamic, I also have to thank some of our partners that are not on the stage. The auxiliary to the National Medical Association local chapter, the Houston Health Organization, certainly MD Anderson Cancer Center, the Houston Health Department, Texas Black Expo for allowing us to sit in their space and to work with us. I cannot forget the faith-based organization, Wheeler Church that's there. We also have 50 Hoops in I guess it's out of Dallas, but it's all over. And so we do want to thank them, the 50 Hoops legends in particular. Other faith-based organizations, I know there's one in Maryland that's on the program that I don't have the name right here. The National Medical Association, of course, and the W. Montague Cobb Institute. And if I've forgotten anyone.
Kingdom Fellowship, AME Church in Maryland.
Yes, thank you very much. Again, they are all important in helping us to put this on. We want you to go out and advocate in your community to keep the information going. We have to keep talking about our health because we are under attack for the next 4 years. Thank you.
Thank you, everyone.